Good afternoon, everyone. Today, our topic of discussion is a bit different from other uh, already discussed matter. Uh, First, we discuss the case. A 49-year-old female patient admitted in anti-emergency with a history of 10 days history of headache, mainly holocarinal, with a few episodes of vomiting, with dizziness and one episode of speech difficulty and query seizure, say 10 days back. And on examination, patient is conscious, obeying commands, moving or folding, no deficit as such, and fundoscopy shows a bilateral early papilledema. Now coming to the MRI, in MRI contrast study and T2 sequence, we can see a very small tumor inside the sagittal sinus, superior sagittal sinus, and a small extra sinus component over there. And in contrast, the tumor is taking up contrast brilliantly. So most probably a meningioma with sinus extension, and that sinus extension causing a venous sinus thrombosis also. There is no visualization of the superior sagittal sinus, and venous collaterals are also very less. So what are the options in our hand in that type of tumor cases? The tumor mainly involving the sinus, and there is no tumor mass effect as per se. So basically three options: just observation and start anticoagulation, followed by radiosurgery (SRS). And second option is subtotal tumor excision. If the extra sinus component of the tumor is much more, then we need to go for a subtotal excision followed by SRS for the sinus component. And third option is the complete tumor excision followed by a sinus reconstruction, and we'll discuss all of this. And sinus meningioma causing the sinus thrombosis is an event where various other complications starts in, like the cerebral venous sinus thrombosis and intracranial hypertension, and associated symptoms of hypertension, like the papilledema, brain edema, occasionally ICH, and also venous infarction. And different modalities like MRI, MRV, and CT angiography and CT venogram are often needed for exact diagnosis of the the condition. And sometimes with papilledema and only plain MRI, it is occasionally misdiagnosed as a CVT. But contrast MRI sometimes is much better to deal out looking at the tumor margins and tumor invasiveness within the sinus also. Management typically combines the systemic anticoagulation to start with to deal with the thrombosis, and later on deal with the tumor, like the tumor control, and includes the surgery, radiosurgery, and the other techniques. The clinical severity of the tumor symptoms depends upon the superior sagittal sinus occlusion. It depends upon a grading system and compensatory venous collateral formation. Failure to maintain adequate cortical venous return due to sinus obstruction may worsen the cerebral edema and neurological outcome. So treatment should address both the venous thrombosis part as well as the tumor part. That is the sinus grading system, sinus extension of the tumor. In grade 1, only the outer wall, the tumor is located in the outer wall. In grade 2, only the lateral recess extension. Grade 3, lateral wall extension within the sinus. Grade 4, the lateral wall as well as roof extension, but the sinus is still patent. And grade 5, the whole of the sinus is completely with the tumor. And the grade 6 is both the walls, roof, everything is involved with the tumor. Now coming to the surgical options, direct surgical options. If the tumor is encroaching on the only one wall of the sinus, then we can remove the tumor and reconstruct the sinus wall with a dural patch graft. And if the dural pressure increase less than 5 millimeter of mercury after the temporary clamping of the sinus, then we can sacrifice that sinus part, because the other venous collateral channels are well formed, so we may sacrifice this kind of tumor and sinus also. And if it is a dominant sinus, then some balloon valve system always used to shunt the blood from proximal to distal part during the tumor excision, followed by either dural patch graft repair or tumor sinus reconstruction. But it is about the single wall involvement of the sinus. But the whole sinus is involved with the tumor. In that case, we generally divide the thing in two parts. Tumor sinus occlusion less than 2 centimeter and sinus occlusion more than 2 centimeter. In less than 2 centimeter case, we generally remove the sinus, occluded sinus and the tumor, and reconstruct the sinus with the dural graft. And more than 2 centimeter segment involvement, then two options are there: a radial artery graft, end to side anastomosis, or a saphenous venous graft, end to end anastomosis. But all this surgical surgical venous reconstruction comes with a complications rate. The surgical complications in those cases, neurological deficit in 10 to 13% of cases, venous infarct or cerebral edema in 12%, intercerebral hemorrhage in 13% cases, and perioperative death around 5.8% of cases. And in incomplete resection, there is chance of recurrence up to 24%. So to deal with that complications, the role of radiosurgery comes in. Radiosurgery is an effective and increasingly preferred option for those type of meningiomas where the sinus component generally deal with the radiosurgery, and the extra sinus component we generally treat by surgery. And radiosurgery is the first line treatment in smaller tumors like less than 3 centimeter meningiomas with sinus involvement or in difficult to treat areas. And for larger and subtotally resected tumors, adjuvant radiosurgery targets the remnant, especially the invading sinus part, and this part reduces the risk of surgical morbidity and venous complications. Tumor control, the progression-free survival after the radiosurgery is around 85 to 95% in 5 years, and in critical sinus location, and 5-year recurrence-free rate is around 0 to 21%. Mostly in case good response is seen in smaller tumors with less radiation dose. And symptom improvement like the headache, papilledema, and visual disturbance improvement is seen after the radiosurgery. And major complications from radiosurgery is only the post-radiation edema. It's around 16%, and with increased dose it occurs. And to deal with that edema, we generally prefer to give bevacizumab or either steroid only. So radiosurgery is especially valuable for surgically inaccessible or recurrent tumors. Tumor volume and sinus occlusion affects the outcome. Larger volumes correlates with the faster recurrence, but not necessarily increased procedural risk for radiosurgery. In summary, radiosurgery either as primary, adjuvant, or salvage treatment offers durable tumor control and symptomatic improvement for superior sagittal sinus meningioma with favorable safety profile compared to aggressive surgery, making it cornerstone in the management of these complex cases. Now coming to the conclusion, SRS we generally prefer for less than 3 centimeter tumor with difficult to treat areas, and adjuvant to surgery after subtotal resection to SRS to control the residual tumor in the sinus. And sinus involvement preferred mode is the SRS because the venous complications chance are very less, and venous thrombosis actually doesn't typically worsen after the SRS, and complications rate are very less for SRS, and outcome has a good tumor control rate and low recurrence rate. Now coming to some examples that tumor operated here in our center. Here we can see a meningioma, parasital location with a sinus extension. Here is the sinus part of the tumor, and that is the extra sinus part of the tumor. In coronal curves we can clearly see the lateral wall of the sinus is breached here, and the tumor extending into the superior sagittal sinus. here also. And it is the post-op scan. The extra sinus part is taken care of. Only the sinus part of the tumor is still present. So we generally prescribe them a course of SRS after 3 months after seeing the MRI scan, and those patients did very well actually. And there's less chance of venous complications, and tumor control is also good. And second example, here's a small tumor, small parasital tumor, but sinus extension is there. But as the patient having a sinus extension, extra sinus portion, reasonable size, and some edema over there, so we and a venous MRP shows a sinus blockage over there. So we prefer to go for a surgical excision of the tumor because there is some edema over there. So here, subtotal excision of the tumor with the preservation of the sinus part is done, and later on SRS was done. And in third case, there is a it's a atypical meningioma. So it's a diffuse kind of lesion, parasital location with sinus extension and complete blockage of the sinus. And that is the post-op CT scan, which shows a extra sinus portion of the tumor is removed completely, and histopathology comes out as a atypical meningioma, and a sinus part of the tumor is still there. We're planning for a radiation for that patient. Thank you.
Any comments or questions?
Targeted in that sinus area. The sinus morphology will not change, altered, and there will not
It is not a radiotherapy. We generally prefer a radiosurgery, SRS, single dose array. They calculate the tumor volume over there and they give a radiation dose, single dose.
So that will not
That
hamper
is not
the
affect the venous architecture. And after radiation, generally venous architecture doesn't change. Actually, the venous flow get improved after the radiosurgery. The chance of venous complications are less with radiosurgery.
I have two questions actually. So often you get single 5 or 6 patients, very large parasital meningiomas, and they don't have any papilledema or anything, only just hemiparesis or something. But in this case, although the tumor is quite small, the patient had early papilledema. Any other factor that might
Only venous collaterals are very less in that case. In some of the cases, in that case, we can see too much of venous collaterals. But in first case, there is no venous collateral. So probably less venous collateral is the main cause of papilledema, early papilledema in that case.
there may be other factors also, like as we see in case of the IIEs. Like the IIEs cases, some patients have got narrowing of the transverse sinuses, unilateral or bilateral. So it can happen in such cases, like what was the patient profile per se that might determine why the patient had got papilledema. If the patient was obese, that might have contributed that some less blockage in the sinuses might have contributed to the raised IC.
And a few days back, another patient came to an OPD, small size tumor, 1.5 to 6 centimeter, parasagittal location, but there was no sinus extension. The only complaint was focal seizure involving right leg because of the patient. So is SRS recommended for this patients or?
Generally, SRS is recommended for difficult to treat areas within the sinus tumor or cavernous sinus area involvement tumor. If it is extra sinus tumor, then better to observe and later on surgery.
Any other questions?
Thank you, sir, for the nice presentation. May I now request Professor Milind sir to facilitate our speakers and panelists.
sir.